Hello, I'm Dr. Omar Bay, and this is A Moment in Medicine. Our mission is health, education, and wellness. Our goal is for each and every one of us to have that opportunity to grow old in good health. Welcome to our show. I'd like to talk about caring and sharing. Sharing by those med moments that we all have. Those episodes in life that let us know that we should see our doctor. Let's come together and let's talk about those med moments on a website called www.medmoments.com. And in bringing to light your med moments, you just may be able to help someone else to stimulate their, will to go to the doctor and see about themselves. We have a great show for you tonight. We're going to talk about gynecological oncology, and it's a big word. And I have Dr. Patrick Anderson, who is a gynecological oncologist, and he's going to give us an understanding of what this specialty in medicine is all about. Dr. Patrick Anderson, welcome to our show.
Thank you, Dr. Bay.
All righty.
Glad to be here.
I'm going to tell you, Dr. Anderson and I go way back. So, Dr. Anderson, can I call you Patrick?
Yes, you can.
Yeah. And of course, you can call me Omar.
Yes.
This is a big topic.
Yes.
And gynecological oncology, I even have a tough time saying it. It's such a big topic. Tell me exactly what it is.
Well, gynecologic oncology is the diagnosis, screening, treatment of women's cancer of the female genital tract, which includes, as you can see on the picture, the ovary, the fallopian tube, the uterus, cervix, the vagina, and what's not represented here is the vulva, the outer part of the vaginal entrance.
All righty. Now, I know this is a big topic, and we only have a certain amount of time, but we're going to cover this, and we're going to have people truly understand after we have our discussion what it's all about. Tell me, in your day-to-day practice, what type of patient comes to see you? I mean, what symptoms are they having that they would come to see you in the office?
Well, first of all, the age ranges includes from pediatric to the geriatric patient. And the symptoms we see varies from patient to patient. But the underlying message here is if you have a symptom that persists, get it checked out. The symptoms range from pain, abnormal uterine bleeding, weight loss, or sometimes symptoms which are perceived as weight gain.
All right. Now, when you say weight gain, you're talking about, are you talking about swelling or fluid or something like that? Or are you talking about the patient just feels like eating and they're just going to?
Well, as I said, symptoms that are perceived as weight gain. And you're so right. These are symptoms that more often than not are abnormal or unusual swelling. Swelling of both legs or just one leg, swelling in and around the vaginal entrance with some other symptoms that may include pain or burning or itching or even abdominal swelling. All of a sudden, a skirt that fit a month ago can't fit anymore.
Right.
And as we are people who love foods, we often chalk it up to weight gain when it really is not.
When it really is not. Now, is this something that I know a lot of times patients may say, I may have a little abdominal pain, or it's just gas, or, so do people usually present early, or is this something we usually see later, as far as presentation for these patients?
I think just to make it make sense, the topic is a broad topic, but if we break it down by disease sites, the symptoms varies from disease site to disease site. So for example, the most common gynecologic cancer in this country is uterine cancer, as opposed to worldwide where it's cervical cancer.
Okay. Now let's break this down now.
Right.
And I don't want you to lose your thought as far as that's concerned. But uterine cancer and cervical cancer, you're speaking big words that that people may not understand. It's different parts of the female organs.
Right. Exactly right. And if you look at the chart again, the cervix is the mouth of the womb. The uterus is the womb itself.
Okay.
Now, the symptoms often overlap. For example, uterine cancer, the most common symptom is abnormal bleeding. Now, it's important that a woman knows herself, knows her cycle. And as a result, when it becomes abnormal, it just does not become an unusual event. She immediately identifies that this is not usual for me,
right,
and see her doctor. Cervical cancer. Unfortunately, when a woman experiences unusual bleeding with cervical cancer, it's already an advanced stage. Now, with cervical cancer, which is cancer of the mouth of the womb, if you look at this picture here, this is a panoramic view of the cervix. We have screening which is quite good, the pap smear. And as recommended, every woman should have an annual pap smear. That varies from time to time. The rules have changed a little bit, but not a whole lot. The bottom line is every woman, especially sexually active women, should have an annual pap smear.
Right. Now, you're talking about young women as well as older women. Is there an age that it should start, or it should start, very young, or how should that happen?
Well, the current recommendation is to begin a pap smear at age 21 if you're sexually active.
Okay.
And a woman over 30 should also have a screening for the HPV, or the human papillomavirus vaccine, because we know that cervical cancer, which is cancer of the mouth of the womb, is on the list of sexually transmitted illnesses. And the underlying cause there is the human papillomavirus.
Oh.
Fortunately, going forward, and we may not experience this for 20 years, we now have a vaccine that we will hope will prevent cervical cancer going forward. We won't realize this for maybe another 20 years, but we're fortunate to have that. In terms of screening for the other gynecologic cancers, cancer of the uterus or cancer of the ovary, when we see patients, or if patients happens to know that they have a particular risk factor, for example, family history, and that family history could be very simple or very complex. It could simply be a mother or a sister who had ovarian cancer or uterine cancer, or it could be part of a larger syndrome, a mother or a grandmother who had breast cancer, colon cancer, or even a father with prostate cancer at an early age. That may be part of a larger cancer syndrome. So whenever there is that global history, family history of cancer, speak to someone about it, because therein the possibility of an underlying genetic predisposition that enables us to begin screening sooner than later.
Okay, so that's very, very important. What you're saying is that it doesn't have to be uterine, it doesn't have to be cervical, but it could be another type of cancer in a family member that would make you think to if a patient comes in with certain symptoms, that this may be cancer with her.
You're absolutely right.
Oh,
it could be part of a larger syndrome, and those syndromes, vary from disease sites to disease sites, or a combination of such.
Okay, let's just step back just for a second. How do you diagnose this cancer, or cancer in general, in your specialty? What do you do to say that if a patient comes into your office and basically she's experiencing certain symptoms, where do you go from there? Do you send her for an X-ray, or what do we do for her?
Well, let's start from the top. Let's start with ovarian cancer, which is the number one gynecologic cancer killer. Yes?
All right.
The reason that is 80% of women who present have already advanced stage, stage 3, stage 4.
Now, when you say stage 3, I know these are big words of staging, but it's important that you understand when you say advanced, you mean that it's spread other places?
It's already spread to other places,
okay.
Yes. Now, the symptoms are often vague, but when you push many patients, they'll tell you, yes, I did feel a little bloated, I thought it was a little gas. Well over 90% of women have symptoms, even quite early, and it may just be a flicker of pain. Now, not to get everyone scared and paranoid, but if symptom progresses or symptom persists, see someone. Right. And we'll all sleep better if when it's checked out, it happens to be nothing. Now, If you start from the top with ovarian cancer, some of these symptoms happens to be some of the swelling we talk about, some irregularity in bleeding, bowel activity, or even urinary function.
So when you say bowel activity, you mean constipation, or you talk about diarrhea? What are you talking about? What type of
constipation, diarrhea, or a combination of both? Constipation this week, diarrhea next week. Okay. Now, if you move down the chart to uterine, again, some of that patient may lay in bed one night and feel, oh, all of a sudden I feel something that I didn't feel before.
Right.
Or, oh, my period came on time, but it's really very heavy. Or a combination of the bleeding and pain or pressure. Yes. And again, cycles varies from month to month.
Right.
And if you're within that age range where you're expected to have a regular cycle and you don't, and the symptom persists, get it checked out. If you're outside that age range, now remember the average woman stopped menstruating about age 53. So if you're 63 and you're menstruating, it's not because you're very fertile and you're still fertile. That may be the case. That's less than 1%. If you're beyond that age range, despite what your church system might tell you, girl, it's nothing, get it checked out. It's an unusual presentation.
Oh.
Now with cervical cancer, as we move down the chart, those symptoms often are silent. The early stages are relatively asymptomatic, meaning no signs at all. But if as a woman you start to have persistent discharge, bleeding after intercourse, an odor that's not usual for you, and by the way, if you have not had a pap test in 5 years or since your youngest child was born, please get it checked out.
All right. Now, once you get your patient to this point and you see the patient, what would be the next step? How would you confirm your diagnosis or make sure that what you're thinking is happening is truly occurring?
Well, there are several modalities, and it starts with the basic premise in medicine. You touch the patient. You do a very good pelvic exam. You do a pap smear. If there's something unusual about your exam.
Just to step back, because not everybody will know what a pap smear is. Tell me what you're talking about. I know you're taking cells, but how do you, not graphically, but, what is a pap smear?
But in layman's terms, you take a small plastic brush. In the past, we used to use just a cotton swab, and you simply smear the surface of the cervix, the mouth of the womb, put it on a glass slide. That's the archaic technique. Or now we have liquid-based technology where we have a liquid, special liquid with a transfer medium, and you just simply wash it off and you send it to the lab. They spin it down, put it on a slide, look at it in the microscope, and they can see abnormal cells. They can even detect certain infections using this technique.
Oh, okay.
Now, once you detect an abnormality on an exam, or from a provider's perspective, if I detect nothing, but the patient still complains of a symptom, then you can take the diagnostic approach to the next level. You can order a CAT scan or a simple ultrasound and see if there's an abnormality there. And if there are abnormalities, there are features within those results that tells you whether there is something suspicious there.
Right.
And mind you, some of these abnormalities may not be malignant. They may simply be benign. But then we'll investigate further. And those investigations may include a biopsy, which is taking a small piece of tissue, which you can take from the mouth of the womb, or there are small devices, which simply in the clinic or in the office, you can get small tissues, or amount of tissue or cell from inside the uterine cavity, or we can use other operative techniques, for example, a laparoscope, where we literally pass a camera into the abdominal cavity and look around.
Okay, so let's step back. There were big words there. When you say laparoscope, you're talking about some type of scope, I'm assuming.
That's correct.
All right. And when you say abdominal cavity, I know you're talking about the tummy region here.
Yes.
And you go inside the tummy region. Now, you don't go inside the bowel itself, like the intestines themselves. Is it around the intestines you're looking, or over or under? What exactly, and just give me an idea of how you do this.
Yes. Essentially, we can make a small incision either through the umbilicus or the belly button, or above, and pass it into the tummy area, and we can look around the intestines, we can look down onto the ovaries, we can look behind the womb, behind the uterus, in front of the womb, we can look up on the liver, we can elevate the edges of the liver, see the gallbladder, look at the diaphragm, which is the muscle between the chest and the abdominal cavity, and see if there are spicules or nodules. I usually describe it as grits on a sandpaper, on a sheet of sandpaper. And if we need to take a biopsy, we do so. If there's a tumor growing in the ovary, then that's an indication that needs to be taken out and assessed in the lab. And in some cases, we can do it with the same technique, just tiny incisions. We can use the same technique, remove them, put them in a plastic bag, bring them out, send it to the lab. They can, in 10 minutes, tell us if this is cancer or not.
Okay, let's just step back again, because I want to make patients comfortable with the procedures that you're talking about. When you say a biopsy, what does that mean? Are you sticking a needle, or are you taking tissue, or how does that happen?
Well, it depends on the approach that you take. In today's environment, we throw out these buzzwords, minimally invasive, which means we try to do a lot through a small incision. So it's not unusual that if in certain circumstances we can have some of our colleagues, namely the interventional radiologists, they can literally deaden the area over the skin and pass a needle into a tumor that's there, and we need an answer, and they can get a core of tissue which can go to the lab, and that will tell us what's going on there. Or we can literally go in with small instruments and actually remove structures that are deemed abnormal or deemed suspicious, remove that and take it to the lab. So it's a combination. It's a combination of taking fluid. It's a combination of taking small core pieces of tissue. It's a combination of removing organs, for example, the ovary, which as demonstrated on the chart here, and send that to the lab. So there are various techniques. And in today's environment, there are often what we call a minimal invasive approach, which is doing a lot through small incision. And the benefit of this is to, allay or the fear of pain that's associated with surgery. But again, moving forward into the 20th and 21st century, that's the approach we're taking when it comes to managing cancers. How can we do a lot? How can we be as radical without imposing pain and discomfort on the patient?
That's very, very important, because I see a lot of patients in my office, and even the procedures that I send them for, the first thing they say is, "Doctor, is it going to hurt?" And a lot of patients, you have to relax them, you have to make them understand, or try to get them to understand that the procedure is going to be done, but you will be as comfortable as possible. And that's very important.
I agree with you, because a lot of times the people I see, that's the biggest bottleneck to come in for care, is the discomfort I'll experience. And sometimes I just simply make one motion. I got you. It's that simple. I got you. Don't worry. We'll be good. And if there's something I can't handle, I have a pulmonologist, I have a general surgeon, I have another surgical oncologist who will help me. And most important, pain management. And that's a whole nother subject. The advances in postoperative pain management, the advances in the comfort that we can deliver in giving some of these treatments, for example, chemotherapy to some of these cancer patients, is untenable. It's unlike what we used to see 20 years ago.
I understand. Now, let's just get to treatment now, just real quick, because I know we've covered a lot, but we're getting to a point where we want to kind of sum it up if we can, but I definitely want to touch on treatment. What kind of treatments do we have for these?
Well, again, treatment, is based on the disease sites. Yes, and if we start again from the top, let's talk about ovarian in a nutshell. Surgery there is surgery, treatment there, is surgery and chemotherapy. In combination or in various orders. In uterine cancer, the treatment primarily is surgical, doing a hysterectomy, removing the ovaries and biopsying and lymph nodes to determine the extent of the disease. Followed by chemotherapy plus or minus radiation if that's necessary. And with cervical cancer, early stages is treated with surgery primarily, but can be a combination of surgery or radiation. With advanced stage cervical cancer, cancer of the mouth of the womb, it can be a combination of chemotherapy and radiation. And let me just add this. in many situations, in early cancers, we can actually treat these patients who are young and want to preserve fertility.
Oh, very important.
Okay, and that's very important.
You know, this subject is so wide, so vast, and I trust that we could go on, and we'll just have to get your back so you can enlighten us more. Dr. Anderson and Patrick, thank you so much for coming on the show, and it was just a pleasure listening to you. Your knowledge and understanding of the topic is just wonderful. Thank you very much.
All right. Thank you, Omar. Pleasure to be here.
Yes, yes. You know, this segment, this part of the show is my Let's Talk segment. And what I'd like to do is just for a moment, when your doctor gives you a medicine, you know, it's very important that you are very comfortable, number one, with taking the medicine. And so there's just certain things that I'd like for my patients, and I try to extend this to other people. When you go see your doctor, you know, ask them the name of the patient, the particular medicine. Ask them the name. Ask them to spell it, because some of these, let alone trying to pronounce it, spelling it is difficult as well. There's also, is there a genetic form of that particular medicine? Because that may be cheaper for you. With all of us are on budgets these days. So if you can get a cheaper medicine, it's very, very important. How to take it? It's important. Should I take it in the morning? Should I take it at night? Should I take it with food? And how much should I take? All of these are very important things as far as medications are concerned. Also, how long will I be taking it? Will I be taking it for a year, or is forever? For my lifetime, will I be taking this particular medicine? Or can I stop it at a particular time? Will I get refills? And will the refills be very expensive? And very important, what are the side effects of this particular medication? These are some of the things that I think that you should know about medication, some of the things that you shouldn't have a fear of asking your doctor. You know, in closing, I'd really like to say that this was such a excellent show, and we look forward to bringing shows like this, you know, that are grounded in medicine and different topics in the future. One thing, as I always close, never institute any change in any medication until you consult your physician, number one. And I trust that each and every one of you continued good health. Remember, I'm Dr. Omar Bey, and this is A Moment in Medicine. Until next time, peace to you all.